Okay, so we are moving to the second part for today after an excellent session by Neba. Part two is heterogeneity of treatment effects. Can somebody look at the picture and tell me what you think that is? One of the interns can tell me. What do you think? Moon and Earth. That is a photo of the Earth taken from the moon. But you can see that there are two pictures. The same picture I have put in duplicate, mainly to show that one of the issues of randomized controlled trials, which I'll explain in the next slide. So, this is also called the parallel universe problem. Has anybody heard of parallel universe problem? So, assume that, let us take Reba's example. There's a child with poor asthma control, and there's another child with poor asthma control. They live in parallel universe. Parallel Earth means all of us are duplicated on another Earth where everything is the same. Okay. So in one Earth, the regular asthma care goes on. But in the other Earth, asthma care with AI goes on. One patient gets better, one patient remains the same. Except it's the same human being who happens to be on parallel Earths. This way we can tell an individual what would have happened to them if they took a treatment or they didn't take treatment. But in truth, there's no such parallel universe. And so what we do in randomized controlled trial, we randomize a large group of patients and we do an average of everybody and they represent one group and the average in the other group represents the other group. But the baseline characteristics on average are same. It's not that every single patient is a mirror image of the patient in the other group. On average, their baseline characteristics are same. But we assume that it's all individual treatment effects, which is not true. That's called the average treatment effect. I'll come back to that many times. So this is called the parallel universe problem, where we assume that what happens in a randomized control trial is an imaginary parallel universe where, if Dr. Vignesh took this treatment in this Earth and then didn't take it in another Earth, then the true difference is between those two, which doesn't really exist. So just for fun, I was Googling this, and now people are having the Hubble Space Telescope and James Webb Telescope, and people are trying to find planets which look like the Earth somewhere in some other universe and saying that, where Google has appeared to have found a parallel universe. It's just currently the stuff of myths. So, a good resource to learn about this treatment effects, which I'm going to take a class briefly on today, is called the PATH statement, Predictive Approach to Treatment Effect Heterogeneity. It's a mouthful, but for somebody listening here or online, this is a very good resource. It was published in the Annals of Internal Medicine 2020. And it's the author is David Kent, and one of my heroes, John Ioannidis, who is from Stanford University, who writes a lot about true research and research which is really not very useful. But for today's talk, I'm going to use this particular talk article which was published in Lancet Respiratory Medicine 2025. It talks about a framework for individual treatment effects. Individual treatment effect means what happens to a single patient. Should he take a treatment or should he not take? So this guideline or this article in the Lancet was a joint recommendation of two groups. One is called practicalplatform.org and another group called the Evidence-Based Individualized Treatment Effects Group or the EVIT group. For some statisticians here who may think this is all a very medically related topic, there is a guideline for statistics in medicine, a tutorial on individualized treatment effects for randomized control studies. So if any of the statisticians are interested, you can look at this particular tutorial in biostatistics and statistics in medicine. Since everybody's into AI, can we use AI to decide which patient to take which treatment, which patient should not take a treatment? There is a particular in NEJM evidence, March 2024. There's an article on how you can use AI to do these things. So the aim of the treatment when we do a randomized control study, all sitting in the OPDs, for that patient, what is the ideal treatment? That's our whole goal of medicine. For you, what's the best treatment? That's called personalized medicine. So, how treatment affects me? I may benefit from a treatment, whereas you may not benefit from the same treatment. So, we must be careful about that. So, the true effect of treatment on outcome for an individual patient is not measurable. Meaning, what would happen if Anuka took the treatment or didn't take? We can never measure. In a randomized control study, we can just say if it is A versus B, A seems better than B. But for Anuka, if she took the treatment or didn't take the treatment, what would have actually been her benefit? We cannot actually say. You can't actually measure it. We can estimate it from a randomized control trial, but it's not the truth as what would actually happen. So that is a counterfactual. What would happen if Anuka didn't take the treatment? What would happen if Anuka took the treatment? Nobody will ever know because we don't have a parallel universe in which there's a human being in another universe who takes it and another human being on this universe who doesn't take. Everything else being the same, what happened to that individual? So we don't have that effect. That is called an epistemological problem. A counterfactual. What will happen to Anuka if she took in this earth? What will happen to Anuka on another earth if she didn't take? And comparing those two, we can't actually do that. So what we do in a randomized controlled trial is called average treatment effect. Why? The average of people in arm A versus the average of people in arm B. That's called average treatment effect. So we are combining the treatment effect for all patients in one group versus all patients in another group. So, and then when we do this NNT and other things, we're looking at the percentage difference in one group, percentage difference in another group. That difference is actually called the average treatment effect, all put together. So that average treatment effect, you can imagine that some people may have a larger benefit. Some people may have a smaller benefit. Overall, average together, what we're getting is a final number, right? It's not that confusing. Some patients may actually benefit. There may be some people actually getting harm in the intervention arm. But average, you may find some benefit. So everything gets averaged out when we're doing what we do in the average treatment effect. So there may be some people benefiting, some people harm, some people benefiting more than others. All is put together in what we do in randomized controlled treatment, which is average treatment effect. So then we can now think about it. Hey, all human beings are not the same. We are heterogeneous. So the benefits of a new drug versus not taking it is also likely to be heterogeneous. So I may respond differently to the treatment, and therefore now we have the concept of heterogeneity of treatment effects. Within the intervention group, each person may respond differently. Within the control group, each patient may respond differently. And that new concept, not new, I try to teach the new concept from average treatment effect, now it is heterogeneous treatment effects. So let's look at two examples, sepsis and ARDS. Sepsis is viral infection. For those online, ARDS is adult respiratory distress syndrome, where the lungs get full of fluid and very difficult for the person to get oxygen. There are many causes of sepsis. There are many causes of ARDS. So that means it's not one group of patients called sepsis and one ARDS. So we find that all new treatments for sepsis hardly anything works. And even ARDS, people have tried so many treatments over the years, nothing has had any dramatic benefit. Now the thing is, take for example, some people say give a lot of fluid for sepsis. Some people put little fluid for sepsis, no difference. Lot of fluid for ARDS, little fluid. Doesn't seem to make an average treatment effect benefit seems to be less. For people with ARDS, high peak versus little lower peak, great benefit was not ever shown in any trials. But it seems to show that some benefit is higher peak. So could there be some patients who benefited in sepsis? Some patients who benefited in ARDS? Maybe some patients got harmed in sepsis. Some patients got harmed in ARDS. So think about this. If some people got harmed and some got benefited, the average will be none. So this is an important thing to consider that in any intervention, if they say intervention didn't work, Okay, maybe some people got a benefit, some got harm, and the average. So let's look at this. An old person, CHF is heart failure, and he's got sepsis. So we often see this in seawater. An older person comes with pneumonia, they got heart failure, and that person, you don't want to give liberal fluid strategy. There's a lot of fluid and he's going to fluid overload and then going to get worse. So he got harmed by the fluid strategy for sepsis. Whereas a young person who got a diarrheal infection and then sepsis, you don't want to give a restrictive fluid strategy, you want to give a lot of fluid. The clinicians can easily make out the difference. Whereas if you bundle both of these patients together, groups have sepsis. Then what are we doing? We're doing a great harm, and then saying that sepsis, there's no difference between liberal and restrictive fluid strategy. So you have to think clearly that there is a heterogeneous treatment effect. So for the this is called goal-directed therapy in sepsis. So there was an international multi-center trial. So they were trying to see how can you differentiate human beings who will benefit from liberal, who will benefit from restrictive fluid strategy. According to that trial, they found that albumin levels predicted who will respond better to one therapy versus another therapy. So they identified one factor that can help differentiate who will benefit and not. Similarly, for oxygen and PEEP is putting high pressure oxygen versus not such high pressure, positive and expiratory pressure for ARDS strategy. And they found that you just give a little bit of PEEP, those patients whose oxygen goes up dramatically, that subgroup of patients are those who benefit in the long term by giving PEEP. Whereas those patients whose oxygen level doesn't go up with increase of PEEP initially, that subgroup will not benefit from that. So trying to show that there may be some heterogeneity. You can't lump all ARDS together and say either give high PEEP or don't give high PEEP. There may be some differences or heterogeneity of treatment effects. So is it a good or bad thing? If meaningful heterogeneity is present, suppose you find if the average treatment effect is suboptimal, average meaning that, like for example, giving AI for asthma patients versus not using the AI intervention, if there was no difference, then you are a bit confused. The average treatment effect is not different, whereas the heterogeneity may be present. Maybe those patients who have more access to AI may benefit versus those who don't. Then you say that there may be some potential benefit. Why not we explore the heterogeneity of treatment effects? We also may be unnecessarily exposing some patients to harm. Why give high peak to everybody? Those patients who didn't respond initially, don't give them the high peak after that. So it's an opportunity for personalized medicine. So this again seems to be the flavor of the season, personalized medicine. So let me just give a visual picture of the same. This is a group of patients. They're all in different colors, suggesting that they're different individuals. Let's say Nishi is a different color, Dr. Vignesh is a different color, and every one of you is a different color. So we will respond differently to treatments. But here we put them into a randomized controlled trial, A versus B. And the average treatment effect was null, meaning there was no difference between A and B. So this is a situation sometimes we may find ourselves. Is that okay? This is the average treatment effect. There was no difference at the end of this particular trial. Now we do some jugglery. Either we say that, hey, let us divide them into men and women, or let us put all the data into a computer and the AI or the logistic regression model or some statistical model can help us to identify three subgroups of patients. In this example, it turned out to be three colors of human being. But when you see a human being, he doesn't come as orange human being, green and red. You have to divide the patients into three groups or four groups based on some decision. So, for example, in Reba's example, it was three blocks based on some clinical decision that these are three different groups of patients. They'll respond differently. So here they divide. The model has divided them into three different colors. When you make these kind of models, you first put it into a statistical program. You can divide them into three subgroups or four subgroups. Then you take a new set of patients with a new set of data and see whether your model worked properly or not. So one is called making the new model, then validating the new model on a fresh set of patients to see whether your model really worked well or not. Then you say, oh, yes, yes, my model now has got three groups of patients. Okay. And can you see that there are three, these colors are separated? What does this mean? So differential effect of treatment based on patient characteristics. Some characteristics could be the age or gender, diabetes, hypertension. The patients have now been differentiated. So you can see that the people who are in purple color, treatment A was better than treatment B. Yeah. And people who are green color or whatever, this color, B worked better than A. And people who are yellow or orange color, A and B had no difference. So this is heterogeneity of treatment effects shown how the model can potentially work. The last part of this one is where do we go from here? And this nicely ties into the previous talk about how do we integrate this into clinical care. So if you have a good electronic medical record with an integrated clinical decision support system, meaning that computer will take into account, you write, you enter your name, age, gender, and you put into that diabetes, hypertension, smoking, blah, blah, blah. It will calculate which group you belong to, the purple group, the yellow group, or the green group. And then it will tell the doctor, hey, this is the treatment for this person, this is the treatment for this person, this is the treatment. So if it identifies a green person, it will tell the doctor, please prescribe B. If it identifies a purple person, it will say give treatment A. And if it identifies a yellow person, it will say there's no difference in the treatment between A and B. You may do it based on cost or availability or access or whatever reason. Right? So this is the entire picture I've put in this, not me, from that article I've taken. So the CDS stands for clinical decision support, but it has to be available at the bedside. So one could imagine that when we're walking around, if we instead of having the workstation on a lap computer, if we have it on a laptop working on a wall bedside, we can actually be making real-time decisions on the spot for each patient using a clinical decision support system. Okay. So the estimation of treatment effects in that previous example that divide the people into three groups, it could be based on a single characteristics. Maybe just gender. Men A is better than B, women B is better than A. Or it could be based on multiple things. Age, gender, diabetes, socioeconomic status, air pollution, family history, so many things put together. Right? So that if you take more than one baseline characteristic and do it, for example, the previous slide, they have taken more than one baseline characteristic to divide people into three groups, not just one characteristics. So if you divide people based on more than one characteristics into two or more groups, that is called conditional average treatment effect. It's not that men will respond and that women will respond, or young and old, or diabetic, non-diabetic. We have three groups based on multiple programs. That's called conditional average treatment effect. The expected effect of an individual with those characteristics. And that's also now called individualized treatment effect. So when let's say Anuka walks in, I say this is your age, this is you will benefit from this. So if you walk in, I say, when you walk in, these are your benefits. Or Lenita walks in, I put your data into the computer, I say, these are your expected. Or Vasha walks in, these are your benefits, maybe no benefit, maybe harm. So this is now called ITE or individualized treatment effects. Right? And it comes from multivariate logistic regression or linear regression or what Weber talked about last, machine learning models. Okay. So the caveat. Everybody thinks this is the magic, we have reached the end. This is only predicting what it may happen. That same parallel universe problem exists. Yes, we think, well, what will happen to you if you take the treatment or don't take the treatment. Unless we really have one you sitting in another parallel universe and you had a treatment in one group and you didn't have a treatment in the other universe, we'll never actually know what will happen to an individual patient. This is our probably best guess of what is likely to happen. It tells, yeah, okay, for your age, gender, this is what I think will happen, but we can never be 100% sure. It's the best we can do at the current moment. So, as experts disagree when we should do it. So, if you put into the computer and find that there is substantial HTE, that's heterogeneity of treatment effects, then they say, why don't we develop this conditional average treatment effect or IT analysis and do that? Some people say only at that time we should do that. Or there's some downside to the treatment. Hey, this treatment, someone might potentially die. Overall, there is benefit. But it seems like some people may also die from this potential treatment, new treatment. A is better than B in terms of mortality. But the treatment A also by itself may lead to some deaths. So then let us try and see if there are some people who will benefit, give it more to them. And the people who are likely to harm, we can avoid giving them the new treatment because those are the people who can potentially, or cost wise. The treatment is very costly. Because let's make sure that we really give it to those who are going to benefit, not those who may or may not benefit. Suppose there's no aspirin for headache. Aspirin is 50 paise a tablet. There's hardly any downside other than gastritis. No need to do expensive IT analysis to identify some food. Cost is less, harms are very low. Don't then do IT analysis for those people. And this is what policymakers take the perspective. Cheap, easy interventions, don't do IT analysis. There are costly interventions, lot of side effects, deaths potentially from the treatment, then you can do the IT analysis. Another view is that, hey, this is a new tool, like a boy's toy, new phone, new something. Everybody must start doing ITE in every RCT, we must do ITE. So then you have a randomized controlled trial, which sounds like an alphabet soup now. I hope I haven't lost anybody. You're an RCT, and there's no treatment benefit between the two arms. What would you call that, Rekha? No, average treatment effect is same. Average treatment effect is what we are usually saying in RCT. So now we'll give you the new word. RCT should no benefit. Average treatment effect is no difference. But there may be HTE or heterogeneous treatment effect. Can I identify a subgroup who will show some benefit? Right. So that's when some people say that we must do that. So there may be meaningful benefit to some people. There may be a risk to some people at an acceptable cost. But this risk and benefit depends on each person's appetite. My mother had a 8th nerve tumor. And the doctor said if you do radiation therapy, you don't have to have major surgery and you may save your 7th nerve. If you go for surgery, 100%, the 7th nerve will also go, but the tumor is out 100%. I said, why do you want to go for big surgery? Just finish off this RT in just 4 or 5 sessions. He said, no, I can't bear the thought of a tumor being in my brain. Even my 7th nerve was, that's true. So her risk and benefit was quite different from mine. So the individualized treatment benefit depends on each human being. You may have a different risk appetite. Somebody else will have, identical to you will have different risk appetite. What they consider benefit, you may not consider benefit. So you must be a bit careful about extrapolating risk and benefit for each person. And we must have a deep knowledge of the treatment as well and the patient's perspective. So if you're going to do this ITE kind of treatment, you have to talk to the patient quite in depth and ask what are your values, what's your benefits, what do you want, what you don't want. So the alternative approach ends with all RCT, we must do a HT analysis and try to find the individualized treatment effect for every patient. So, what is the guideline currently? This part statement which I gave you earlier, predictive approach to treatment heterogeneity. So, they are really conservative. They say, suppose an RCT shows benefit. In that state, do the HTE. Because then we can identify the subgroup of patients who will benefit more and the subgroup of patients who may not benefit from the treatment. Null ATE means the RCT which did not show a difference. They say don't do heterogeneity of treatment effects. You may be simply fishing around trying to find some subgroup and do that. But you may come up with some spurious subgroup just by chance by doing multiple analysis, and then you may land up doing that analysis. So they also give an exception. This is the suppose there's a new treatment which has mortality as a side effect. Okay, then you'll say that even though there is no average treatment effect, meaning the two arms are the same, maybe I can identify a subgroup of patients in whom mortality benefit is there. I can identify a subgroup of patients where, in fact, the new treatment may increase mortality. And therefore, I may try to do heterogeneity of treatment effects, even though the average treatment effect is the same. But this is the only caveat in which they suggest that one must try to do a heterogeneity of treatment effect. Okay, enough of theory. Let's look at some examples. This was an earlier trial which came in 2019 in the New England Journal of Medicine. So, once you intubate a patient, that's called mechanically ventilated patient, should we have a higher oxygen, 97% and higher, or a free oxygen strategy? So, the first and the outcome was 90-day mortality, and 0 means there was no difference in the two oxygen strategies at 90 days. And this is the average treatment effect. Do you think there's a difference on this one? It's crossing the 0 line. So there is no difference on the average treatment effect. Then on the y-axis, you can see what tertiles of predicted ITE or individualized treatment effect. So they divided the patients based on what they thought there are three tertiles of groups. So they found that in the people with the lowest risk, there was no difference. Mortality crossed 0. In the second tertile, there was no difference. But people with this third tertile of predicted risk, they actually seem to favor a higher oxygen current. So though the average treatment effect was not different, they did manage to identify a subgroup of people in whom they said actually giving oxygen will make some benefit. Yeah, so this is the kind of analysis they're trying to give. I'm just trying to show the black square is the average treatment effect. In this picture, the rounds were the individualized treatment effect. This is called the ICU rock study. Anybody intubated a patient recently in the ward? Nobody? None of the residents? Okay. So if you intubate a patient, there are two devices which can help. This is called a stylet, which we put inside the endotracheal tube to make sure that it goes in easily. We can also do something called a bougie, which is you just visualize the vocal cord, put this plastic tube into the cord first. That's easy because it's a thin thing. On top of that, you thread the endotracheal tube. So they did a randomized study control trial. It's called the bougie trial, and it is published in the JAMA. This is the publication. Bougie versus endotracheal tube with stylet, and looking at successful intubation on the first attempt. The intubation is quite a tricky business, and this is the publication. What do you think of the average treatment effect? Somebody else? The first one? No difference. But they also looked at quartile 1, quartile 2, sorry, this has sort of moved because I put this picture here. This is quartile 4, 3, 2, 1. The bottom has moved a bit. You can see that there seems to be some difference in the treatment effects when you stratify them based on this. This is a third trial, and this is called the REST trial. So patients who are critically ill, there's a low tidal volume, plus there's a device like an ECMO device which removes carbon dioxide. So low tidal volume plus removing carbon dioxide strategy. So this is the visual abstract from the JAMA. They took 405 patients, 200 to the low tidal volume plus carbon dioxide removal, and 205 patients to the traditional strategy. And the outcome was all-cause mortality at 90 days. Now you all got used to this picture. Is there a difference in the average treatment effects? No difference. But if you divide them into quartiles of predicted ITE, you can see that in quartile 4, actually it favors control. In other words, there is a harm from doing the CO2 removal. So now you say, oh, this new strategy actually may find harm. So therefore, I told you the exception is part. If the new treatment may potentially cause mortality, then you should try to do this IT analysis and say, hey, that it's better not to try and offer this treatment. You may actually find a group in which you're offering harm. So this is one example of that. This is called the REST trial. Okay. So what is your purpose for doing this IT analysis? Are you going to make clinical decisions? Let's say you're in cash register anytime you say, oh, this patient will benefit from CO2 removal, let's do it. So you're using the IT analysis for actual clinical decision making. Let's say like a triage in an emergency. Or you may say that no, this is only a research tool. I just want to see what's happening for the future. So there are three goals which are possible. There is heterogeneity of treatment effect in a given population. Different patients respond differently to this treatment. So I'm looking at treatment decisions, actual patient care I'm going to make. So that's one reason for doing HT analysis. I want to see which patient. The second one is the direction and magnitude of effect. How much more will this patient A benefit from B and C? So I'm trying to see that, okay, if I give this with this baseline characteristics, who will benefit more, who will benefit less? So I'm trying to stratify patients based on the ITE. How will they respond? The third thing is to generate a hypothesis. Hey, none of my new treatment for ARDS is working. I don't know why it's not working. Maybe there's some subgroup is working and some subgroup is not working. And then when I put the average together, it's all showing as null. So I do the IT analysis to generate some hypotheses. And the IT can now tell me that there seems to be 3 or 4 subgroups. Then I look at those subgroups and then I make a biological rationale. Oh, younger patients who have diarrheal illnesses benefit from liberal fluid. I have identified one subgroup. Older patients with heart disease and given liberal fluid strategy seem to go into fluid or reversal. There must be a biological rationale why these two groups are different. So last one is hypothesis generation. To try to understand, just to get some scientific rationale, we do IT analysis. The first one is to see two groups. The second one is to see can I stratify the people and say how much benefit I get in the three groups. There are many different methods of doing this HTE and IT analysis. Just remember that this is not causation. If you find three groups and one group is better, don't say I've causally found out. There's an association between group 3 and benefit and or harm. It is not causation. It's a statistical association. Causation means it must follow all the principles of either Cox postulative and microbiology or Huss principles. Modified Bradford-Hill criteria for other medicine. They do not show that the age is causally responsible for somebody benefiting. There's an association between age and benefit. There's no causal relationship between age and benefit or harm. So the other thing is, if you are saying that I'm going to do HT analysis, let's say one of the statisticians is asked, can you do HT analysis? When the RCT was planned, they should say that we suspect there may be heterogeneity of treatment effects. Therefore, statistical analysis plan includes HT analysis. This is what we're going to do. What we shouldn't do is after the RCT is over and the trial found no difference, meaning average treatment effect was same, then we shouldn't start now saying torturing the statistician, please do HT and find out. That's the guidelines. But there's no harm saying that average treatment effect was not different. Exploratory analysis, we did HTE or ITE or CAT analysis to try and identify. But as long as it is exploratory analysis, post hoc analysis, we never planned it, then the reader will know that we never planned it. We just tried to find something as an exploration. So just we'll end with these pictures. Is there a difference between the treatment in the two groups? This is a treatment group, this is the control group. Y-axis is mortality. You can see there's a slight difference, no? That is called average treatment effect. The same thing which I told earlier, I'm just showing a different picture. So there are some people here also who are this, some people here, some people above, some people above. Or on average, this seems to be slightly more than this. So the mortality in the usual care group seems to be slightly more in the control group. This is called average treatment effect. So the conditional average treatment effect is conditional, it could be conditional on a single characteristic. When we say single characteristic means I'll divide them into men and women, diabetic, non-diabetic, above 65, less than 65. Traditionally in the RCT we call that as a subgroup analysis. But if you do that on multiple characteristics, then only is called conditional average treatment effect. So here we got conditional average subgroup analysis. So you can see people more than 65, less than 60. Now this is the subgroup of more than 65. This is a subgroup for less than 65. You can see that there's a slight the benefit seems to be quite more in, I mean, that seems more in the more than 65 compared to the harm which is potentially present in the less than 65. Is that clear? This is a traditional subgroup analysis. Let me do that again. This is the treatment group. This is usual care. This is mortality on the y-axis. In people who are more than 65 years, there seems to be a increased mortality in usual care. Whereas people who are less than 65 overall, the usual care group seems to be having a decreased mortality. This less than 65 is correct. This should have been more than 65. So how does the conditional average treatment effect? That means you can't find more than 65. Aggregate of many risk factors put together. The picture looks something like this. This is the conditional average treatment effect. So you group people based on quartiles of risk. Can you tell me anybody here a score for sick patients in ICU? SOFA score. What else? Apache score. Apache is acute physiology, means your age, your sodium, potassium, lactate, oxygen, create, and chronic health evaluation. Whether you have a heart disease, kidney disease, cancer. So the Apache score is a good score which combines both acute physiology and chronic health. And based on that, you can divide people into different risk groups. So one could think of this as, sorry, it's pointer now. As low risk based on Apache score, medium risk, moderate risk, and high risk. So now you have reclassified people based on the score, let's say Apache score for mortality, and you can look for treatment A in each quartile, how will the improvement be? Understood? So now this is a conditional average treatment effect based on different quartiles of Apache score. Right. So the effect-based model of HTE. So you can even put this in AI model, right? And the AI model will tell you these are the patients who are going to get harmed by the treatment, and these are the patients who are likely to get benefited. And the difference between that is called the individualized treatment effect. The patient, if he had taken the treatment versus not taken. It's like the imaginary parallel universe where in one universe you took the treatment, in one universe you didn't take the treatment. It appears like a parallel universe, but it's really not. So, how is that different from the Apache score? Apache score only takes your baseline physiology and your long term. This also looks at the treatment group, whether you are going to take the new treatment or not, plus interaction between these variables. Interaction means your age may interact with the gender. The age may, the treatment may interact with your age or gender. There is an interaction between people's groups. So all that together is taken into account in the computerized model or the AI model, and the AI will then tell you, or the statistical model will tell you, what is your chance of benefiting from the treatment, your chance, each individual's chance of benefiting or not benefiting. So that is individualized treatment effect. Predicts how an individual might respond to treatment A based on multiple baseline values. It is not just Apache score plus the treatment you're going to get, plus interaction between these variables. It can even take into account, AI can say, you're from a poor socioeconomic background, you're from an area of high pollution, you've got lower education level, all that what we don't traditionally take into account, the AI model can put everything into and tell individualized treatment effect. So I thought I'll just end there. Tomorrow, next Saturday, we'll take part 2 of this heterogeneous treatment effects, a little more deeper dive into that. But are there any questions?